for our last but certainly not least panel presentation today, we're going to be talking about final action steps. So the panel's called Making It Happen, Approaches to Dietary and Lifestyle Change in Clinical and Community Settings. And for this one, we're going to be led by a faculty member from our School of Public Health, Aimee Afable, who is our Associate Dean for Community Engagement. And for over 14 years, Dr. Afable's research has critically examined conceptual frameworks used to understand health disparities and health inequities. Her work has documented the declining health advantages with increasing stay among U.S. immigrants and has questioned the validity of the healthy immigrant paradox. She has a growing research program in community engaged approaches to the development of urban health interventions. And she's currently co-leading 2 NIH studies that use community-engaged implementation science frameworks. She is going to be joined today by representatives from plant-powered Metro New York, from the New York City Department of Health, and I'm sorry that I don't have my paper up here with me. Who's? Dr. Dhuper from Live Light, Live Right. So I would like to welcome you all up to the stage for our last panel. Thank you.
Good afternoon, everyone. Thank you for staying this whole time. And thank you, Beth, for introducing us. We're going to flip the script a little bit and hopefully even address some of the earlier questions that came up, in particular, what are the challenges in the real world to integrate lifestyle modification into our daily lives and at a higher level, at the population level. And so, as Beth mentioned, I am a health disparities, health equities researcher. And so, the theme of this panel is really to understand lifestyle medicine or lifestyle modification, which is the goal of the lifestyle medicine. What are the challenges and how do we approach a solution from a social ecological perspective, right? And so I didn't hear a lot about social determinants of health today, and so we're really going to tackle those issues in our discussion, in our panel. And so I am delighted to present, our 3 panelists, and I have asked each of them to present some slides to give a little sense of who they are, but also what are the resources and what are the models of care for chronic disease and management that their organizations are promoting and offering as a resource. So I guess we'll begin first with Lianna.
Thank you.
Yes.
It's great to be here. And keep your eyes open, because I know you're starting to have that decline, but hopefully it'll be lively. Okay, so I'm Lianna Levine Reisner. I thank you for coming over to our table at the networking hour. It's great to speak with many of you. I'm a co-founder and the network director of Plant-Powered Metro New York. I personally got into this work trying to feed my children and wondering how to keep them healthy. And in the process of making dietary change, I reversed the symptoms of endometriosis, which no healthcare practitioner had ever spoken to me about in regards to food. And I was pleasantly surprised that I also had a very healthy weight 3rd pregnancy after having 2 very heavy pregnancies, thanks to what I think is due to dietary change, and a lot of great postpartum benefits as well. Plant-Powered Metro New York, for those who haven't heard the spiel, we are a community-driven organization that is promoting plant-based nutrition in the community, and we're looking at all different sorts of ways of helping people with behavior change. So it's not just telling people that plants are effective for their health. It's also giving them the tools to learn in a way that feels comfortable. We're not there to preach, we are there to guide. And then to give them the next step, which is, what are my take-home activities that I need to do? So whether it's going to the market and looking differently at what's available at the produce stand or in the grocery store, being able to read labels, being able to know how to cook in your home. And we do not cut corners. We teach about a plant-exclusive approach, knowing that anybody can add more chicken to their dish if they want, or they can put a lot of extra calories on through oil if they'd like, but we teach oil-free nutrition. We teach in a way that is giving them an ideal vision of where they can go, and that way they can make choices about how far they'd like to go. In our programming, and maybe I'll advance the slides, our general, this is the mission, we are there to catalyze a movement for change with diverse local communities, and so we have a network of educators and volunteers and chefs and healthcare professionals who we deploy all over the region to do training and education and to provide support and community. And through that, we have assembled a really wonderful and very multicultural team, people who have personally made change and who are able to be ambassadors within their communities. You've met some of our folks here today. We have three mentors in the audience, Lisa and Enrica and Rotasha, and a few of you who've participated in our Jumpstart programs, which I'll talk about next. Just very briefly, like the theoretical framework for what we do, we're trying to get at behavior change in service to health change, and so we provide a variety of different activities that first raise awareness about what plant-based nutrition is and help people to get curious about it through storytelling and through a connection to the evidence. But then we go deeper through education, just learning without any commitment, and empowerment being the next step where we have activities that guide people toward making changes to improve their health. And once they've gotten to know how to do this, of course, there's the support element, which is how do we support people in further, making a deeper commitment to eating a whole food plant-based diet, but also making the tweaks to help improve over time. So I'm going to speak briefly about our Jumpstart program, and then we can dive into a little bit more in the panel discussion. So we have our plant-powered Jumpstart program. We've been really happy to work with Downstate over the past 3 years to study the program. So we have a little bit of data on it now, thanks to the work of graduate student Lianna. The plant-powered Jumpstart, we are running it now in English and in Spanish. And here's the context for it. We offer a virtual program, so we deliver it online, although we're about to do one with in person at Downstate this summer for people who've received a kidney transplant as a separate study. But our general programs are open to the public, and we're getting people from many different backgrounds into the program. We are recruiting heavily from community organizations and healthcare organizations that we have connected with over the course of the past few years. And we do get people who join from outside of the region because it's online and people can join from anywhere. So we have people from the West Coast, and we've even had somebody from England in the program. We also create accessibility by offering tiered pricing. There are certain programs that we run that are grant funded, that are either free or very low cost. Our general programs, we offer tiered pricing so that there's a discounted rate for folks to join if they don't have the ability to pay the full price. And we ended up with a very female population. I think it's about 90 to 95% who are female who join. I think you all probably know why that might be. But also there's a lot of racial and socioeconomic diversity. And I think that's in part thanks to the relationships that we have with certain kinds of community organizations who are encouraging their constituents to join, also our own mentors and people who we have been in the Jumpstart before are great ambassadors to bringing in new people. So we end up with a really nice diverse population. And we have anywhere from 60 to 200 people in a program. We just did a program in April in Spanish that had 60 people. We're right now doing a program with New York City Health and Hospitals employees, thanks to their sponsorship, with 200 people. And usually our English programs land somewhere in the middle. So that's the context. And then what do we do with them? The inputs are weekly educational sessions through Zoom. We have usually somewhere between an hour and a half to 3 hours of programming through Zoom each week. And then we have peer mentorship. So that's like the secret sauce of the program. Everybody who's in the program gets put into a small group that's led and facilitated by either one or two mentors who we've trained from the community. And they're not health coaches. They don't have the credentials that Chris-Anne has, but they're people who have lived experience with the lifestyle. And so they guide people on the path and answer their questions and field WhatsApp questions and share food photos in between sessions. We offer a lot of resources and recipes through a program app. We take people who are local on market tours in person, which are optional. And we also do make sure we address medication safety. Although we're not a healthcare organization, we have medical advisors from our advisory board who help us to do some intake and make sure the folks coming in who are on diabetes medication and on hypertensive medications know what they need to do to monitor those medications, because we're not going to be responsible for that. They have to be responsible for it. And the last thing is we bring produce to those who are food insecure. So we work with a produce delivery company and make sure that folks can have the option to opt in to receive a box during the program. And of course, should we get more resources to run these programs, we'd offer more than one box, because it would be great to give them produce once a week. So that's the program in a nutshell. Probably more time than I should have taken, but we'll move on from
No,
here.
Lianna, that was perfect.
Thank you.
Okay, thank you, Lianna. And next we'll hear from Dr. Sarita Dhuper, who is the Executive Director and founder of Live Light, Live Right, a childhood obesity management program.
Thank you so much, Aimee, Beth, and for all the organizers for the invitation. My background is also I just stumbled upon this sort of career path, and it's become a big part of my life. I'm a pediatric cardiologist, again, like Dr. Rosenfeld in the pediatric space. Did all my education first in India and then here in the US, and studied did my fellowship in New York City, and then I moved to Brooklyn. And in the first few years of my career here in Brooklyn as a pediatric cardiologist, where we learned nothing about nutrition, nothing about saving patients who become adults, all we knew was congenital heart disease. And then though I have many success stories, my career started with tragic stories. The first two patients which are referred to me, which really made me start this program, were two kids who were over 300 pounds, and they were referred to us to rule out heart disease because they were breathing too heavy and they were getting shortness of breath. Both of them ended up having diagnosis of dilated cardiomyopathy, which is very large hearts, and they had to go on a transplant list to Columbia. Unfortunately, both of them were refused because of their obesity. So they were refused to get heart transplants, and they passed away. Both of them passed away. We had plaques in their memory. And it always brings back a very sad feeling. And then after that, I started looking at why is this happening? And more and more patients were referred to me in this neighborhood. I was at Brookdale Hospital first, and then at Downstate. They were coming in with hypertension, prediabetes, diabetes. And I'm talking about the late 90s, early 2000s. I'm talking about 20 plus years ago. And at that time, obesity was not even on the surface for kids. And we started this program, Live Light, Live Right, using community coalitions to see what we could do to treat the actual underlying cause for all these conditions, and not just treat them with medications for their blood pressure or medications for their lipids, which we couldn't for kids. And so now Live Light, Live Right was funded by the Robin Hood Foundation for many years and the New York State Department of Health. And we were able to create our own 501c3 organization, and Dr. Afable and the School of Public Health have really helped us promote this at Downstate and other neighborhoods. It basically is a 4-part model, but what drives it is understanding obesity as a disease. And when I say understanding obesity as a disease, I mean severe obesity. I don't mean anybody who's trying to lose weight. That's not a disease. That's the desire to be thin. So we have a big difference between that. So anyone with a BMI of over 35 with comorbidities, that's our major population. And it's a chronic, progressive, relapsing disease. So while we've talked about all the 6 or 7 or 8 or 9 pillars which we keep adding, and we do all of those in our practice, this is still a relentless disease. In spite of doing all the lifestyle modifications, sometimes, some studies have shown there's just a 3 to 5% improvement in intensive lifestyle modification. We can show, like you said, you could show the good signs, you could show the bad signs, but people who are 35 BMI and above, no matter how much intervention you do, they lose the weight and they gain it back. So this chronic relapsing disease is what we're trying to understand, and it affects the physical, mental, and the mental health trajectory of the children and adolescents. So it's a pioneering healthcare model focused on childhood obesity prevention, but mostly multi-level treatment, both primary level, secondary, and tertiary. And we serve mostly the catchment area is Brooklyn, central Brooklyn, 37% of our patients under the federal poverty level. Majority of them are Black kids, 86%, and Latinos, 12%. We offer complete in-depth evaluation, and I'm a board-certified obesity specialist now. Like they have the American Board of Lifestyle Medicine, we also started this American Board of Obesity Medicine in 2012, when I first took my boards, and the first time it happened, I was just waiting for that so I could get certified and not be talked about just as a pediatric cardiologist, because I do not treat my patients like a cardiologist. I treat them as an obesity medicine specialist, give them a holistic approach. We do body composition, fitness assessment, individual care, and nutritional counseling with a certified nutritionist, but we will direct the nutritionist based on what the needs of the patient is. It's not like one size fits all. Someone has a high hemoglobin A1C, someone has a high dyslipidemia, someone has high triglycerides. We then offer everybody virtual or in-person trainer-led exercise classes. They're at the Brownsville Recreation Center, and they were at the Flatbush YMCA's, but after COVID, that stopped. We have weekly cooking demos and nutrition classes, which teach them how to use all the things you've talked about today, all the new ingredients, new nutrition, ways to bring plant-based foods inside, ways to substitutes. And then, just recently, over the last 2 years, we have advanced treatment for severe disease, which is chronic and progressive. We've used weight loss medications or weight loss surgery if necessary, and definitely that has helped some of the kids who are struggling with obesity. We have community engagement, powerful partners in this field which help us do what we ought to do. And again, this is just showing you the model stage 1, stage 2, stage 3, stage 4, all working together. The green boxes tell you that stage 1 and stage 2 is exactly lifestyle modification, exercise, diet, mental health, all the pillars we talked about, sleep. And the next two the slides are stage 3 and stage 4 are intensify the treatment. Don't wait. They say pediatricians should start the treatment as soon as they see the child is getting obese. Don't wait, this will go away, this is puppy fat, this is this. Just start your treatment straight away and do what you have to do, and multiple layering approaches. That's my contact information, and thank you again.
Thank you, Dr. Dhuper. Could you just comment, or I don't know if you clarify if the resources that you provide, the exercise activities and the cooking classes and the workshops, are they free
Yes.
to the
Only the medical visit, thank you for reminding me, only the medical visit was covered by insurance, and if whatever the insurance, and most of us are Medicaid managed care. So, it's really not much to cover. The rest of it is now supported by friends and family because it's a 501c3, so everything is free for the patients. But of course, we would provide them much more when we had the grant from Robin Hood Foundation. We were providing many more classes, but the grant lasted 14 years. We're very thankful for them, and then COVID came and monies went off to other poverty beings. So if anyone knows who would like to support, please let us know, but it's free for them.
Okay, thank you. Thank you, Dr. Dhuper. And finally, we have Maggie Veatch. She is the Brooklyn Director of Health Equity and Capacity Building at the Center for Health Equity and Community Wellness at the New York State Department of Health and Mental Hygiene.
Thank you so much. Okay, so I work for the Health Department. We are in the Bedford office of the Bureau of Brooklyn Neighborhood Health. That's in Bed-Stuy. We mostly focus on Brownsville, Bedford-Stuyvesant, East New York, and Bushwick, although we do a fair amount of work in East Flatbush because there's some maternal mortality and high rates of diabetes here that we've talked about before. And our main goal is to eliminate health equities and health disparities that exist in these neighborhoods. So just bringing it back a little bit, this day today has been really enjoyable for me because it's been on one-on-one clinical and patient medicine, which is very much different from the world that we work in. So when we think about public health, we're looking at how do you change the life expectancy for 8 million New Yorkers. And there were gaps in life expectancies for New Yorkers before COVID. And as you can see in this map, the life expectancy has dropped dramatically during COVID and after COVID. And one of the things that I really want to talk about that we haven't really touched on a lot today is how environment drives life expectancy and health outcomes. And so we know during COVID, Black and Hispanic people died at disproportionate rates. And we know that this is because people had jobs, they had to be out in the community more, there were less protective factors. And then even when COVID vaccination became available, oftentimes COVID vaccines and COVID vaccine vans were placed in communities that were more convenient, where there was more traffic, versus the communities that had the lowest rates of vaccination, which just kind of exacerbated the issue and the challenges and created disproportionate equity issues. And so this is where you can see the gap here, and you can really see that who bore like the brunt of the burden of COVID, and even before COVID, different chronic diseases. To what I was speaking about before, COVID, chronic disease and premature mortality doesn't happen just randomly. It doesn't happen, and we've talked a little bit about genetics. We've talked about different lifestyle choices, which all matter and are all incredibly important. But what we also know is that it has to do with like structural racism and like city investment. And so where money is invested, where are there the most parks, where are the most grocery stores, what schools have PE, what schools have gyms, even the New York City Department of Education, they have excellent school food, but some schools have kitchens that have space and capacity to chop up the food and prep it nice and hot. Other schools are just warming kitchens. And so the quality of food and the quality of resources that children and people across New York City varies dramatically, and you can see that in this map. The three circles there represent kind of the areas that our three offices, bureaus of neighborhood health equity work, Queens, Harlem, and South Bronx. Wait, no. Brooklyn, Harlem, South Bronx. We're trying to open an office in Queens. Is anyone from the mayor's office still here? I was going to pitch this. They were like, they're like, oh, we should talk to your Queens person. I'm like, we've been trying to get a Queens office, but I was like, I don't know, I'm going to get in trouble for that. So hopefully they're not listening an online stream. And then this is just a circle. This is diabetes. We could do this with high blood pressure. We could do this with HIV. We could do this with maternal mortality. We can do this all day long. And these, for folks taking pictures, these are also available on EpiQuery online, these maps. And we just, again, showing that the disease burden is concentrated in certain neighborhoods, and it's concentrated in certain neighborhoods because of the resources that are spent and poured into the community. And the other thing that always gets me too with like the food, we talk a lot about money and cost and access to food, but one of the key things is that when you live so far out, you got to commute to work, and you come back and you get back at 6:15 or 6:30, and you got a choice to help your kids with the homework, make sure they get to bed on time, or stop and grab food on the way home, and the healthy food options aren't always there. And something that we always hear when we come to communities and we talk about food access is just the desire to have fewer fast food restaurants in communities with high burdens of diabetes, and more cheap, accessible, healthy food that you can grab on the way home. So it's not always lack of money, it's just a lack of time and resources.
Before you change that,
yes.
I just wanted to, I don't know if everyone could see the numbers, but it's going up to almost 19% is that South Bronx?
That's the South Bronx, yeah.
And around 17% here where we're sitting, which is markedly higher than the national rate of 11.4%. And also, I was asking Maggie before the panel whether these are based on self-report or not, and apparently they are. So you want to clarify? So basically, this is an underestimate of diabetes in New York City. So I just want everybody to aware, it's much higher here compared to the national aggregate average, and that 11.4% is not only based on self-report, it's based on NHANES, which actually goes and collects blood and diagnoses diabetes. So we're really disproportionately affected here.
Yeah, and I just wanted to flag too, like these neighborhoods also have hypergentrification. So for like Bed-Stuy, one of the neighborhoods we work in, and like when I started working there in I was a little around 2010, 2011, there was maybe I started 2012, 2013, but the last data we have is 2010. It was like 94% Black or Hispanic, and now it's like 50%. So this data gets delayed, and one of the things that happens is that the people who are Black and Hispanic in the neighborhoods are getting even fewer resources, because when you look at the overall numbers, like this happened with COVID. This is my work, this is my job, this is our team. We looked, we're like, Bed-Stuy, it's got like an 88% vaccination rate. We're gonna focus on Weeksville, we're gonna focus on Brownsville, like East New York, like these other neighborhoods that are struggling. And then they disaggregated the data by race, and Bed-Stuy actually for Black and African American people had the lowest rate of vaccination in New York City. And this was because that looked fine. And so when you were looking to focus where to put resources, you didn't think to look there. So this is something the health department we're also working on, is to make sure our sampling reflects the hypergentrification and the displacement that's happening in neighborhoods that have been historically Black, African American, or Hispanic. So So this is green. Okay, so this is the Diabetes Health Equity Initiative. I actually really like this color. This is a little different than I put it in, but it ended up matching. So as I mentioned before, one of the things that we think about in our work in public health is we're trying to think about how do you scale this. So when I hear these lifestyle interventions, when I hear all of these things that are happening, this is fantastic. All doctors, all clinicians should be working with their patients that way. How do we reach 1 million New Yorkers? How do we reach 2 million New Yorkers? How do we make sure every single person in New York City and even across the country has access to lifestyle interventions? And so what we decided to focus on are funds. You heard me talking about COVID. The funds that are supporting this money are public health core funds that were initially funds used for COVID. And so once COVID kind of finished, we looked at COVID recovery funds and how do you address chronic disease? How do you eliminate the burden of preventable early deaths due to diabetes, hypertension, and the different chronic diseases? And so we decided to focus on, like my team, decided to focus on diabetes. And we wanted to develop a network of evidence-based diabetes self-management classes that's consistent, predictable, and accessible to all who live in Bed-Stuy. We wanted to focus on one specific neighborhood. One of the things that we learned during COVID that you kind of knew before, but with COVID we got a lot of data, was that when you try to be in all places at the same time, it's really difficult to do interventions in 3, 4, 5, 6, 50 places. And if you can just focus in one area, in one community, and go deep for like a few months or even a year, you can really have a population level impact. Diabetes self-management classes have been shown to be as effective as the medication metformin. They're workshops that consist of 5 classes, and people who finish the classes have similar outcomes to if they were prescribed the medication metformin. And then the other thing that we wanted to make sure is that everyone in the neighborhood we decided to focus on was Bed-Stuy are aware of the classes. And the reason for this is that oftentimes in public health, we want to reach like this certain population. We're really, in our minds, we're really targeting 45 to 64-year-old people for a whole bunch of reasons that there's other slides on. I'll talk about at some other point, but not today. But you want to focus on those people, but we know that in the communities that we serve, in all of our communities, it's often your spouse, your sister, your mother, your brother who wants you to go and take these classes. And we also know, too, that I think 1 in 3 households have diabetes, have someone in them living with diabetes or prediabetes, and so you don't know when you're going to get diagnosed. But when you get diagnosed, you want to be like, oh, I just got that postcard in the mail, or I saw something at the bodega, or I think I got an email about a diabetes class, because that's the time that you're most likely to take the classes upon diagnosis. And I'm just going to wrap up real quick. And I think I've gone on a little bit, but I just wanted to say too that the way that we did this is, it's not that we set up the classes. One of the things that happens in the neighborhoods that we work in is that there's often little bits and pieces. So you have Riseboro and Interfaith Hospital, One Brooklyn Health offering these DSMES classes, but they're having a real hard time recruiting people to go to them. And then we have like these faith-based organizations or senior centers who's like, we have all these patients with diabetes who don't know where to go, but we don't have anyone to teach these classes. And so a lot of what my work is doing is like trying to stitch those different pieces together and have like a centralized location where people can find out about the classes. And then again, too, these consistent, predictable level of classes and structured outreach. We reach out to all to retail outlets, to senior centers, to food pantries, and just really go deep in Bed-Stuy. And this is, so far, this has been great. Before, when we started this out, there were no classes offered. And this is a little map of Bed-Stuy. We have hosted, there's 14 classes that we're hosting, 7 are completed. I actually think 3 are in progress and 4 are, and 4 are scheduled, and we've had 167 people registered, which is really kind of the target because we don't want a full, you only want like 6 to 8 people per class. Beyond that, it gets a little difficult. They're goal-setting classes. And this is due to our partnerships. What Lianna mentioned is, it's the women. Like this is like, I was like, run the demographics, I got a presentation to do, and it's like 87% women. So this is also a question to you or to everyone out here is like, where are the men and how do we get them engaged and involved?
Okay, great. Thank you so much, Maggie. So a common theme in a lot of these, your introductions is getting people to attend. And I feel like what Department of Health is doing in Brooklyn is you're leveraging the assets that exist, community assets that exist, so that, you're working with partner organizations that are already delivering the DSME, et cetera. I wanted to ask the panelists, what are your experiences with that in terms of, it seems like from Lianna's perspective, they're having a lot of success recruiting, although, we have to address the gender divide, but it seems like you're having a lot of success recruiting, so I wanted to get your take on, what is it about your programming that will attract these individuals to these programs? Given that, there's a whole robust evidence base on lifestyle modification, we all learn about the DSME that Maggie just spoke about. There's also the diabetes prevention program, which is the gold standard diabetes prevention trial that was published in early 2000s. But still, fast forward to 2024, we don't see DPP at least integrated into routine care, and why is that? So what are we doing? What are you all doing to promote participation in these programs?
Yeah, I'm happy to start. So I would say that the most important thing we can do is invest in relationships. Some of you have heard me talk about this before, but when I mentioned that we have this network of individuals in the community from many different walks of life, and we're recruiting through community organizations, the way that we do that is by spending every month of the year, and sometimes every week of the year, out doing things. This weekend we have 2 different teams going out to 2 different events. We're here today, we've got 3 more next week, and at every place we go, some group, usually it's 2 to 5 people from our network, is there talking to people, sharing stories, and really, preaching about how powerful this way of life is, so that when the time comes when we have our virtual program, which may be somewhat more accessible to certain people, but inaccessible to others, we do have sort of an ingathering of people then, but it's very intentional. Every single time we run a program, I reach out to this church that we just did a program with 2 months ago, or that community center that we've had a relationship with for 3 years, and all of those pieces together feed people in. I would think that it would be harder if we were just in one spot in a community and trying to get people in. So the goal is not to draw people to us, but to become magnetic through our relationships in the community. But that takes a lot of investment of people and resources.
Dr. Dhuper, do you want to add to potential, perhaps, barriers or facilitators to addressing sort of the real-world challenges that our populations face with regard to preventing diabetes and obesity and chronic disease?
Sure. So going back, this has been a long journey. As I said, it's over 25 years. So the first 10 years we spent in understanding the disease ourselves, trying to train our local physicians who, needed to be trained in nutrition. And those were the barriers that people did not know that this could be a serious problem. And then going into the communities, going into schools, churches, health fairs, and just keeping the word out, getting the word out, like you're saying, going everywhere to make sure people are aware that this is a resource. And then you start getting your referrals, and people know this is a resource. They're going to send their kids here, and then the kids get better, and then they have community engagement, like we are talking about social relationships. So the barriers, the major barrier came into that we are always treating disease, but we are not understanding that unhealthy eating, sedentary activity, obesity, increased weight gain, all these are diseases. The body is not regulated. And to try to explain that to a layperson, forget about a layperson, try to explain that to physicians, we don't understand that. And all of us are telling patients all the time to do this and do that. And there's no empathy. It's always the blame. It's always the patient's fault. So that takes a lot of barriers. That's the biggest barrier, because if a patient comes into your office and you're going to blame him about his weight, or you're going to blame him about... So the first thing we try to teach families and patients, deal with patients when new residents come in, to start with saying it's not your fault. You've got the weight problem, and then explain the genetic environmental interactions, which Maggie, you know how much we did. For every talk, we worked together on many events, and to tell them how the epigenetics works and how the environment has become so toxic and so obesogenic. No matter your genes were there to protect you, from losing weight many millions of years ago. So that's a huge barrier. People don't understand that, right? They don't understand why this is happening to them. Now those same genes in this environment are just being reprogrammed, and they're redirected, they're re-expressed to store more fat. And the more fat you store, the more hungry you get. So most of these patients are chronically hungry. Now, I always start with my plate and explain to them eating the fruits and vegetables, start with at least one fruit or vegetable, because there's studies shown that if you eat your fruit before your meal, you will reduce your ghrelin level, you'll reduce your insulin level, which are the hunger hormones, you'll feel less hungry. So now that's a way of helping. That's a way of helping these patients understand. But if you just give them advice and not explain to them what's going on in their bodies, why they're not their fault, then you can engage the kids. So engaging the kids is most important because they've just come here with stigma, with weight bias, with fat blame, shame. We have a full psychological assessment, and 90% of them don't want to look at your face when they're in the office. They want to look up at you. So first is just having them connect with you, and then giving them these little steps, which basically don't do anything too much except engage them. They're not going to really change a pound on the scale. But over a period of time, at least engaging them is a very important aspect. And then those community events we had were very important. The resources we offer them free are very important. But sometimes free didn't help because they still didn't come. So we're not still sure what exactly works. Each one is different. Some people love it, some people hate it. So we are still learning. But last thing I'd like to add is adding the I know we all have been against medications today, but I must tell you that sometimes you need it. Just like an asthmatic who's severe asthmatic, you can't tell them just be out of pollen or be out of the environment. You still have to give them the nebulizers. You still have to take. So the anti-obesity medications have changed the way their appetite regulation is. They're feeling, for once, they're feeling not that craving, that hunger. They're coming back losing 10, 20, 30 pounds for some of these kids. And then they're now exercising more. They're eating healthier food. So I think a combination is really helpful.
And any of the panelists can answer this. Can you elaborate a little bit more based on your experience? I just want to also elevate that everyone here has been working in the community for many years. So it seemed like, there's this idea that we have to be there, and build trust with the community. Part of sort of establishing this or promoting participation in these programming is sort of establishing trust with the community. And it seems like that is also a recurring theme. But I wanted to get a better sense of, if the panelists can comment on what are the structural barriers. I know Maggie talked about it a little bit more. Can others speak about, some of the structural barriers or the social determinants of health that are serving as, barriers to getting better sleep, or barriers to, we all understand it's not that easy to buy it's not cheap to buy a salad. It's cheaper to buy a Big Mac than it is to buy a salad here in New York City. And so do you have programming that addresses that, or can any of the panelists comment on that?
Maggie, do you want to speak?
I think the health department is looking towards that increasingly. It's so yes and no. There's health bucks where you get, I think it's 3 health. It's been a while since I've been under mine. Like for every $5 you spend, you get an extra $2. There's new programs. There's for NYC Cares members. There's a program called Groceries to Go, where people get $100 a month to online order groceries. There's another program that the Bureau of Chronic Disease is running, where you're starting to see, like, if people go into certain grocery stores, and if you have SNAP benefits, you get an extra $50 or a certain amount for fruits and vegetables every month. And so I think that's the direction that we're going in. I don't think we're where we need to be at scale yet, I would say.
Other panelists?
Yeah, I find that the problem is about food preferences. Most of our patients, we've asked them, and we've done, one of the students did a social determinants of health questionnaire over the summer for our family members, and I was surprised to see that more than 85% said they had access to fruits and vegetables. They did not have a problem buying them. They have them at home, they have to throw them out, they go waste. So most of the time, it's a food acceptability problem for our families. The kids just hate eating fruits and vegetables. So there is definitely, they're underprivileged. They don't have the resources, which many of us have. So we cannot just compare. They have gym-free memberships, but they don't go there. Planet Fitness does a full free membership all summer from May to end of August, free for all teenagers to come in. I mean, that's excellent. And I mean, 20%, 30% also will not join. The Fresh Air Fund does free exercise programs all summer, which is outdoor camps for two weeks at a time. We've partnered with all these organizations over the years. We've given them free access to everything. But I think it's just adapting to that and accepting that and going with it, which is the problem we are finding. The resources are there.
I'll add that, yes, I also agree that many people in New York have more access to healthy food than they may be familiar with, and so that some of that is just an educational opportunity for us. We at Planned Parenthood Metro New York generally are not working with people with severe food insecurity, so I don't have that experience to share with you. But I do think, as I've said in a few different forums, that when you give people the lenses through which to see their food system differently, they start to understand, even if they can't make change. And I know there's been a lot of talk in the various panels about incremental change. Part of the reason why we, in the Jumpstart program, encourage people to make much more substantial change all at once is because this may be one of the most effective ways to change our food preferences so fast. So there's research, of course, on how we are addicted on a biological level to foods, whether they're processed foods or animal foods. And unless we create distance between ourselves and those foods, it's very hard for us to just live in this state of limbo in between. As many people have talked about, you can't tell an alcoholic to just have a little bit of alcohol. And so if you just have a little bit of processed foods in your home, actually it's really tough to avoid them. And so I think that part of our imperative in public health is to be a little bit more extreme with our messaging, because people need more extreme measures to deal with the extreme rates of chronic disease that we have. And I think there are ways to do that that are loving and culturally relevant and sensitive, but we have to sort of hold up a higher standard and show people what's possible, because when I share Rotasha's amazing story, Rotasha no longer has asthmatic symptoms anymore and no longer has prediabetes anymore. People don't believe it because they haven't heard that it can be possible. But it is possible when you take more drastic measures. So I think that may not be a structural barrier, but it certainly is a perception barrier, a mindset issue. And I think we need to address that as well.
Great, that's a great point, and that is an excellent point. I don't want to take up too much time. I think our panel is over, but I want to give the panel just one more, if anyone wants to add anything regarding, any additional educational tools or resources that you found most effective in facilitating lifestyle change, please do so before, I guess, we take questions from the audience. Have we covered everything? Go ahead.
I think the one thing I would just say in terms of recruiting folks is authentic community engagement. Dr. Afable talked about the trust with folks, and so we don't go on the streets and flyer. When we go to retail stores, we don't just say, hey, can we drop flyers? We engage, hey, do you know anyone with diabetes? We're worried about this, we're worried about that, to bodega owners. And bodega owners are not our primary audience. We want them to get help. But we found that when we actually engage folks, the other folks sitting in the store hear it, and we can see on Eventbrite that they click on it after we leave. So our community health workers go out and they're like, what was the point of that? And I'm like, I can see the point of that because I can see that 20 people have clicked. So even though they didn't engage with you, that kind of engagement, when we try to recruit people on streets, we don't say, do you want to take our diabetes class? We say, hey, we have some questions about health in Brooklyn. Here's this, here's that, blah, 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 10 or 15 questions. And then at the end of it, here's a bag, but would it be okay if we added you to our diabetes mailing list? And so we found that to be much more effective than kind of a direct approach to recruiting people. And that was true for COVID vaccination as well. Thank you.
I think we have a great source of resources from the DOH, the food planner, the food plate. What I think is necessary is to engage more physicians, medical students to learn this for the future, to make sure the EMRs, the electronic medical records, actually have all these resources so you can print out at point of care. Those are not being done. I mean, this conference is great, and we don't have any medical students, we don't have any medical residents, And though I sent it to everybody in the pediatric department, they should be attending these conferences. They should get the resources. From a doctor's point of view, we're just 2 or 3 doctors here representing this whole field of diabetes prevention. And I think your community members are doing such a great, better job than all the physicians are doing together. So I think we really need to get the physicians on board.
I'll also say, just because we're in a healthcare setting here and an academic setting, the main resource that we need to keep fueling is the awareness of our medical professionals. And I'll give you one story just as a closing from my perspective. We have one of our mentors in our Jumpstarts who reported back, this was on March 14th, so about 2 months ago. This was 4 months after a Jumpstart that he had been involved with, and one of his mentees, one of the participants, got back in touch with him to tell him how things were going. Now, this was a woman who had come and held up a huge bag of meds in their very first mentorship session. And he says that she burst into tears as she was pretty much housebound. She told her doctor she was starting this program, and he tried to dissuade her, as he said it would mess with her treatment. However, 4 months after she completed the program, she's down 40 pounds and counting off all of her diabetes meds and insulin. She lowered her blood pressure meds, and she's on the path to get off of it. And the only thing she says, just like what Dr. McMacken said, I wish I knew all this information sooner. Mm-hmm. We need to do better, and I think healthcare really has to be on board with all of that. So I'm grateful for all of you to be in the room and so many of you already sharing the good news with your patients.
So, can you start right there? The question, yeah.
Hello. Hi, my name is Lynette Townsley. I'm the Youth Committee Chair for Community Board 12 in Queens. And thank you so much. This has been very empowering. So I'm sorry, this is very emotional for me because my dad is diabetic, and he's in an assisted living program at Boulevard in East New York, Brooklyn. And it's very hard for me. He gets Medicaid and Medicare, but it's very hard for me to help him with a plant-based diet because he believes his doctors. And when I went to the doctor and asked them, we want to do a holistic approach, they told me that you need to get a naturopathic doctor. It's very blatant that, no, we're just going to put him on insulin, and that's that. Where I'm trying to, I helped him to do the plant-based, but then even in the assisted living, they have chocolate cake. And I'm wondering why we're not, although the facts show that the food that are in our communities, especially in the Black communities, are addictive, why we're not treating this like drugs, because that's what it is. When we grew up, I'm 53, we didn't have all of these dialysis. You had one hospital, and that was because you fell or something and broke something, not for these diseases that are, it shouldn't even be. So I'm just concerned why we don't treat it as a drug, because that's what it is. In addition to, I work for United Parcel Service, so I couldn't stop working during COVID, and that's when I turned plant-based. I could not find healthy food choices in my community, and I live in Addersley Park in Queens, one of the most wealthiest urban communities. And my local store, the Stop and Shop, when you read the codes, the 3, the 4, the 9, whether it has pesticides, but it's also not real food. They have fruit with no seeds. So it's not the same thing. And I have to go 2 towns away just to get real food so that I could use food as my diet. So we have a really challenging time, and we really have to call it what it is, because even with my dad, it's insulin. They're not looking for anything else, and I would have to pay out of pocket just to service him or help him. Thank God he did start doing a plant-based, but then he couldn't eat where he's living. He had to come to my house. So now he's off of the insulin, and I think they have the pill, but it's still challenging because if I'm not there day to day, it's addictive. So he's gonna go to the food that they're giving him. So if there's any way that we can really talk about what can we do for our communities to really help them with the foods that have become a drug.
Dr. Dhuper.
Yeah, I agree with you, and I didn't want to say that, but in my clinic, I always tell my patients that this food is addictive. There have been a number of studies which show functional MRIs when these kids are just, or humans are just exposed to some of these high-calorie, high-processed foods. Their brain cells, the areas in the brain which are pleasure-seeking will just light up. So these foods bring immediate pleasure, just like smoking does, just like marijuana does, just like opium does. So these are absolutely addictive foods, and that's what we are working against. So these kids are used to having ultra-processed foods, which are making them sick and causing the disease. So as I already alluded to, that the healthcare professionals are not trained to do this, they're not thinking of it like this. So we have to work with community members, we have to educate each family that these foods are addictive. And the more they eat of this, the hungrier they'll get. So one of the commonest things that the kids, I said, come to the office, they say they're hungry, 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 hungry all the time. So again, we're talking about medications. If you treat addictions like with other sort of treatments like Alcoholics Anonymous, you may have to do group sessions to detoxify these patients, which is not really available right now. So for obesity and for diabetes, it's approved. Medications are approved. How they're working on these axes. Now, nobody wants to accept that because they say long-term you're going to be on these medications. But if you're addicted to something, you need that.
Oh, but what about, so aren't cleanses or in some form, some lifestyle modification programs are considered,
Yeah,
cleansing?
they are, I'm sure, but they're limited in, they're not, again, accessible to all these patients, and these kids will not do, not kids, even kids who are people who like ultra-processed foods, they don't want to do those cleansings or, they just want to keep eating. But there are alternative, but they're for the privileged people.
Yeah.
Right, and I don't think that they don't want to do it. They don't have access because plant-based food is delicious.
Yes.
We've experienced that today. They don't have access. And I think even as a government, when you give SNAP, look, you have to buy healthy food, but then we also have to have healthy choices.
Yeah.
So, yeah. So I'm going to just a couple of things with that. One of the things that's really interesting, and I can't find this, but the mayor's office a couple mayors ago, or one or two, I don't know how many mayors ago, did a really fascinating study that people spend the same percentage of their money on produce, no matter what your income is. So if you're making $200,000 a year, you're buying like chopped organic pineapple and spending, I think it was like 12% of your money. And if you're making $20,000 a year, you're spending 17% of your income on produce, and you're buying like a bag full of apples that you can stretch, and probably not as much. The other thing that I wanted to talk about, we did, and I'm going to get some of these data points. Oh, sorry. But it's, we're ready
Could
to
you wrap
let's
up?
just go.
One more question, or? Okay.
Oh, we
yeah,
need to finish. Okay. I just wanted to talk about food marketing that's targeted towards Black and Hispanic people, and they're specifically children under 2. And so it doesn't just happen that folks walk out and they pick an apple over this. There's an aggressive marketing campaign that happens, and it's been, like, food marketing has been banned in other countries to children under the age of 18, and that's a policy level decision that was talked about a lot several years ago. I don't know what's happened with it.
There are more questions. It's up to,
Yeah.
we'll take one, yep.
Okay. Thank you so much, everyone, for all the work that you guys are all doing, and the doctors and all these programs. My question's about kind of piggybacking on sustainability, and I don't know if the mayor's office is still here, but how to make it more sustainable. Like you go to these neighborhoods, there aren't many, there's the bodega for the groceries to get healthy food, and My question is there any work on, for example, like community gardens on apartment roofs, or putting grocery stores in those sort of desert areas, you know, in New York, and where there could be a grocery store where you could get healthier options? So yeah, that's my question, just more community gardens, you know, and that would even fuel the oxygen in New York and everything, so.
So I can do real quick, there's a Fresh Food Initiative, which reduced a lot of the burdens for grocery stores to open up in neighborhoods. So there are tax incentives, you don't need a parking lot in New York City, and several different things. So that's been somewhat effective. The other thing that happens with hypergentrification is that grocery stores open up, and like the grocery store across the street from me, it's $9 for half a gallon of organic milk. I mean, like, come on, you know, they're like, that's not reasonable. And so, So yes, there's stuff moving further, and there's also the Shop Healthy program that helps bodegas have healthier food offerings as well.
Okay, well, thank you so much, everybody. I know that there's a lot to talk about. We're just scratching the surface. Thank you.